You can start.
Hello, everyone. It is a great pleasure again to welcome you to another edition of PCR Heart to Heart Conversations. As you already know, this series is broadcasted live on PCR Online, where you can ask questions. But apart from that, you can watch us live on the X platform, as well as on Facebook, LinkedIn, and other platforms. Today, I'm joined by an esteemed colleague and a friend, Azeem Latib, from the Montefiore Health System in New York. And our task today will be to discuss EuroPCR 2025 in terms of innovation, clinical practice, and education. Azeem, thank you very much for being with us today. It is a great pleasure to see you.
Hi, Dejan. Thank you so much for having me on Heart to Heart. And I'm really excited to be chatting to you and to all the listeners.
Thank you very much. So, as you could see from the title, our outlook on the past edition of EuroPCR has brought some new things in terms of three segments: innovation, clinical trials, and education, and they all come together. So, I would like to start with innovation. You're one of course directors of EuroPCR Innovators Day, which takes place in Paris one day before the start of EuroPCR. Can you tell us more about the Innovators Day? How does it work?
Yeah. Thanks. Yeah, so Innovators Day, like you said, starts on the Monday of the PCR week. We've been doing it for a number of years, and about 4 or 5 years ago, me, Pepe Caliado, Nico Piazza, and Nicole Karam became the course directors, and our task was really to try and make the Innovators Day into an exciting meeting where everybody in the innovation ecosystem would want to come. And I think that's what we've been able to do. It's really a fun day where if you're interested in innovation, if you want to design a device, if you want to get involved in new devices, if you a strategic who's wondering what are the new devices we have to think about buying, or if you're a venture capitalist who wants to invest money in the next range of devices, PCR Innovators Day is the place for you to be. It's the one place where you can be sitting right, in a row, and next to you is a CEO of a company or the vice president of Medtronic, and you can have coffee with them later and have a conversation about new technologies and innovation. So it's a very special place and a very special day. And it's all about bringing everybody together in a small room where everybody involved in innovation can talk, can network, and get to know each other. And that's really, truly the basis of Innovation Day.
Great. So, my question to you now is when we think about innovation, where does it take place currently in terms of moving forward? Coronary or structural or valvular interventions? How do you see it? I mean, I have seen some innovations in the coronary space as well, in terms of calcium management, for example, but how is it that you see it?
Yeah, absolutely. I think, the one thing you realize when you come to Innovators Day is that innovation is pervasive in everything we do. So many people think that coronaries have gotten boring and there's nothing innovative. That's not true. There's still a lot of innovative technologies. And if you think about why we need innovation, it's because we want to address unmet clinical needs, right? That's what innovation is really about, is, you know, how do we address unmet needs in our daily practice with novel technologies and novel devices? So I would argue, like you just mentioned, in coronaries, there's still a lot of unmet needs, right? Take calcium modification, take microvascular dysfunction, take intracoronary imaging, right? And so can those technologies or those unmet needs be addressed by innovation? And so we're still seeing new technologies in coronaries. We're also seeing how AI and artificial intelligence and large data is coming across the different fields of cardiology and to try and help us make better decisions. Obviously, structural interventions remains at the forefront of innovation. There's just so much investment and growth in that area. And then another area where every year we see novel technologies is in the heart failure space. This whole concept of sort of interventional heart failure, because we as interventional cardiologists work together with our heart failure colleagues and use devices along with GDMT to help patients with heart failure.
So do you see most innovation happening there in the heart failure space? Not in as much as that it has already been moved forward in a way that you have clinical trials in that space, but yet you have new possibilities opening up in that space. And when you contrast this with the structural coronary, where you already have established pathways within which you work in terms of innovation, is heart failure space something which is sort of starting from scratch?
Well, not completely starting from scratch, but there's certainly a lot of innovation, right? So one of the things we have at Innovators Day is what's called the John Dehan Award. So every year, people can submit their innovations to Innovation Day. They get judged, and the top three innovations get selected to be presented. And the top one will win $200,000 to help their innovation. Pretty big deal, pretty big award, right? And what's interesting, out of the three technologies this year that were selected, two were in the interventional heart failure space. Okay, just to make it. And the winner
Yeah.
was interventional heart failure. I feel kind of a little bad because I was competing too and I lost because there was a very cool technology, using the diaphragm to help cardiac function, right? I mean, who would have thought that you could put a sort of like a pacemaker-like device to stimulate the diaphragm to improve and help cardiac function. I mean, those are the kind of novel things that, some of us we're not even thinking of. And then you come to Innovators Day and you see these technologies and you go like, wow, there's so much we can do and in ways we never even thought of. And I think that's what I love about innovation is sometimes the most interesting innovations are the ones we can't think of or are the ones staring us in the face at times.
So, since this is a heart to heart conversation, I will have to ask you a question. Of course, what was for you at EuroPCR 2025 Innovators Day the most promising innovation from your subjective, let's say, feeling?
Right. Wow, you're really putting me on the spot. Um, I, I think what I really liked was we maybe I'm going to choose two. We did a whole session on lifetime management and on innovations that will help us with lifetime management in TAVI, right? So one of the biggest challenges is how are we going to treat patients who have a failed TAVI valve? How are we going to do TAVI and TAVI? And how are we going to address, coronary access? How are we going to address patient prosthesis mismatch? Just putting a valve inside a valve. So there was a whole session on that where, we saw three or four technologies that are going to help us address leaflets. I thought that was really interesting because again, it shows how in interventional cardiology we find a problem, okay, and we go, that's the problem, and then we try and find innovations to help us address the problem and to make the treating the problem approachable to everybody, right? Because let's face it, doing a basilica procedure, which is to lacerate the leaflet, is not easy to do, and not everybody can do it. And so, can technologies address that? So I thought that was pretty cool. And then there was a technology to address patients with ascending aortic dissections, okay, to do
Percutaneously.
simultaneously an endobental procedure, which kind of looks a little crazy, but to me, that's wow. That's like the last thing, right?
Yeah, yeah.
Because we
The
could
last
put aortic
frontier.
valves in, we can put we can treat abdominal AAA aneurysms. But one of the things that's difficult to treat, and many patients are not candidates, is an ascending aortic aneurysm. So there was a technology where you could replace the valve. You could almost do an endobental where you re-access the coronaries and you almost like you reimplant the coronaries percutaneously, okay? And then you put a big graft in to push the dissection. I mean, that to me,
That's
it's
great.
far-fetched, but
That's
it's
great.
great,
Yeah,
right?
yeah.
Because it's really out there and it shows what innovation is about. It's how do we address things that we couldn't address before, and how do we help patients that maybe we couldn't help before?
Now, as you mentioned the word far-fetched, So let us transition to the next section of this mini conversation, and that is clinical trials. So innovation, it's really forward thinking and trying things out in humans as a pilot or on animals which are not yet ready, let's say for the clinical arena. And then there is a plethora of clinical trials and studies that are being presented at various conferences throughout the year. And the distinguishing question for me, at least, when looking at those studies, is which is going to impact the clinical practice, which is going to have an impact on clinical practice. And there were several major clinical trials, late-breaking trials presented at EuroPCR. And there are two which I would like to speak about with you in terms of this, in terms of their impact on practice. So let me start with the first one. The first one is at a cross-section of coronary artery disease and TAVI. It was presented by Professor Flavio Ribichini at EuroPCR, and it's called FI-TAVI. So it's a randomized study with roughly 300 patients and who had severe aortic stenosis. Mean age was around 86, which means elderly TAVI patients with coronary artery disease, but intermediate lesions, meaning that on angio it's between 50 and 90%. And then they would be randomized they were randomized in two groups. One was FFR guided and the other was angio guided. Angio guided meant that you basically stent or you perform PCI in all those patients with angiographically looking stenosis more than 50%. And FFR arm was very interesting. So if FFR was below 0.80, you would proceed to PCI. If it was above 0.85, you would defer to medical therapy. And interestingly, if the FFR was between 0.81 and 0.85, you would actually repeat FFR after TAVI. So that was interesting to me, and I would like to hear your comment afterwards. The primary endpoint was in favor of the FFR guided group, and it was a combined endpoint with that all-cause mortality, MI, TVR, disabling stroke, and bleeding at 1 year. And most of the events, or most of the difference, was actually driven by the all-cause death and TVR, and there was a non-significant difference in stroke also in the same direction, benefiting FFR. Now, of course, all-cause death and stroke cannot be, let's say, immediately related to the FFR guidance, unlike TVR, and that is something which can also be discussed. But the first question to you is, how do you see this trial impacting our practice today?
Hi, Dejan. Yeah, so, I think the trial addresses an important issue for us, which is how do we manage coronary artery disease in patients who have aortic stenosis who need to undergo a TAVI procedure? And when I think of it, for me, there have always been three important questions, really. The first is, do we even need to treat the coronary disease? Okay, we don't even know that question yet, and I'm going to get to that a little bit later. If we do treat the coronary disease, do we treat it before the TAVI, during the TAVI, or after the TAVI? And then the third question is, when we do treat it, what's the best way to treat it? Is it using physiology, or is it just based on angiography? So I think what the study helps me is with question 3, is that when we do decide to do PCI, and I think this just confirms our overall approach to PCI, right? That we've learned now for a number of years, based on all the physiology-based studies, is that using FFR-guided PCI is better than angio-guided PCI. That in general, when we use angiography alone, we end up treating lesions that may not need to be treated. We put in too many stents, and we potentially will result in worse outcomes. I think this study again confirms, and it's important that it did that, because there's been a lot of discussion about whether you can use FFR in the setting of aortic stenosis and patients undergoing TAVI. So what I take away from this is that if and when I need to perform PCI and the patient has 3-vessel disease or multi-vessel disease, clearly if there's a stenosis that's over 90%, that's easy. But in the stenoses that are less than 90%, I should be using FFR to make my decisions as to whether I need to treat that stenosis or not. All right. And
So
I
do
think
you?
that's what the study helps us with.
Yeah. So would you agree that the question whether we should treat an angiographic stenosis of more than 90% was answered also by the Notion 3 trial, where we basically had most of the lesions like that, severe angiographic lesions. And what could argue that those lesions, even though they are severe, if they are not causing chest pain in elderly, very elderly patients, that are known to undergo TAVI may be left alone. And I think Notion 3 filled that gap, saying that we should treat those lesions even if the patients are elderly and not necessarily having chest pain after TAVI.
Yeah, I agree. I mean, I think Notion 3 is important, right? It helps us understand, that there are some patients who will benefit. But remember, when you looked at sort of 2-year mortality in Notion, right, it wasn't statistically different, right? And then we also had activation, which was also, didn't show a benefit from doing BCI. So to me, the question that you just answered, you asked is, in an elderly patient who has coronary disease and needs TAVI, do we need to always like fully revascularize them? Do we need to do PCI if they're asymptomatic and they have chest pain? I don't believe we truly have the answer to that. There's a very large study underway called Complete TAVI, okay, which is over 2,000 patients randomized. And there the patients are going to be randomized after the TAVI procedure to PCI or no PCI. And I think that's going to give us the final answer because you really, to answer this question, you need a large sample size. And that study is over 2,000 patients. So I think that's going to help us really understand that question that you ask. And I struggle with that question. I don't treat everybody who has coronary disease. There's sometimes I'll decide, they're asymptomatic. I'll do the TAVI and I'll follow them up. And if I see them in my outpatients and they're having no chest pain and no angina and they're 85 years old, maybe that's okay. I'll leave them alone. I'll treat them medically.
Let me ask you a final question regarding to this. Since I would agree with you that we do not have a definitive answer based on the trials so far that we should or should not treat every coronary artery disease that we see. But the question is, when do we have to make a decision regarding treatment? Because you said Complete Tower is going to be after TAVI, making this decision at all. And all
Yeah.
of the trials that I just mentioned, and you mentioned Activation, Ocean 3, 5, TAVI, the decision was actually taken, or the randomization was before TAVI. So the question is, when should we take the decision regarding coronary artery disease? Because the symptoms, of course, could originate from the aortic stenosis itself.
That's a great question.
Yeah.
And again, I wish I knew the answer because it's one of those areas where we need more data. But I'll tell you about my practice, right?
Yes. Yes.
Um, because I think it's always good to share one's own practice. When I started doing TAVI, and I've been doing TAVI for almost 15 years now, for most of my career, when I first started doing it, we went into this with almost the surgical way of thinking that, if you're going to treat the aortic stenosis, you have to treat the coronary disease and you have to do full revascularization all the time. And so when I first started doing TAVI, we were revascularizing everybody before the procedure. Okay. Then we said, but maybe we don't need to treat that small marginal branch. And we had all these other data from, on medical therapy. Then we started moving to, oh, you know what? I'll just treat the very tight lesions during the TAVI procedure, a little bit like they did in TAVI and in Notion 3. But I have to say, again, I've changed because I realized that a lot of the patients, their symptoms, even the chest pain, is coming from their aortic stenosis. And so now my current practice is in most patients, I do the TAVI, I see them again, at 30 days. And if they are symptomatic or they have a very tight proximal vessel that needs to be treated, I will treat them later. And when I do treat them, for the lesions that are intermediate, I'm going to be using FFR and I'm going to be using intracoronary imaging to make sure I get a good result. But my practice has changed to now I first do the valve and then the PCI later. And one of the advantages of that, Dejan, is we always teach our colleagues that treating coronary disease in someone with aortic stenosis is considered complex PCI, right? Because if
Yeah.
something goes wrong, you then have the PCI complication in a patient with severe aortic stenosis. So I think take the aortic stenosis out of the question.
Agree. Agreed. So this is how we tend to do lately as well, but it's
Hmm.
still a conundrum. So I guess future trials will tell us more. Going back to the second trial or second study, which really did impact practice, I think. It's a meta-analysis, more than 10,000 patients, on basically combining data of two large randomized trials, Protect Tower, and the second one is the British Heart Foundation, also Protect TAVI trial. So basically, those two trials tested whether cerebral protection device is needed when performing TAVI on a routine basis. And both trials, as well as meta-analysis, did not find a significant difference. So it would look like a routine use of cerebral protection definitely is not needed. However, in a secondary analysis, digging deeper into the pooled data set, did show a difference in a disabling stroke overall and disabling strokes in a prayer protocol analysis. So can you first tell us what is the difference between an intention to treat analysis in a trial like this, where you have a device which you need to place, and a per protocol analysis, which I guess means that the device was ultimately placed as it should be? So what is the difference between the intention to treat and per protocol for this specific question? And how do you think this will impact our practice going on?
Yeah, great question. So intention to treat is like you said, it's, you randomize the patient right at the beginning, okay? And you leave them in their two groups, even in the treatment group, even if they didn't get the treatment, the experimental treatment, you still analyze them in that group, okay? The per protocol, you're going to analyze them based on how they were actually treated, right? And I think that's important because the two studies were very different, right? In in protected TAVR, you only randomize patients based on the CT analysis and whether you thought you could actually put a device. Because the thing with Sentinel is you can't put it in everybody. There are a lot of anatomical exclusions based on, innominate tortuosity, the how aggressive the aorta is. We have a type 3 aorta, whether there's plaque in the innominate or the carotids. So they and the size of the vessels. So um, there's at least 15 to 20% of patients you can't treat, even if you wanted to. So in protected TAVR, they already excluded those patients. So the patients that were enrolled were only patients who could be treated. In the British Heart Foundation study, they randomized without knowing the anatomy. So you had patients in both groups or in the treatment group that were just anatomically not feasible. And that's why you had to do this two different types of analysis, because in the British Heart Foundation study, there were a lot of patients, not a lot, but there were some patients who were randomized to getting embolic protection that eventually did not get embolic protection. Okay. And so those will cloud the data a little bit and take away some of the treatment effect.
So the question to you is then, how do you see this field moving forward? So do you think that embolic protection devices have a future, given that the rate of disabling stroke was around 1% and the overall rate of stroke was 2.5%, perhaps?
Yeah. That's a great question. And I think, when you look at the field of embolic protection, there's often more emotion involved than actual sort of scientific rigor or logic involved, right? And I take you back to when this embolic protection device got approved in the United States. It got approved through a panel of physicians who made the decision, and they were all faced with a study that was completely negative. Okay. Yet they approved the technology. And you know why they approved it? They approved it because in the study, they showed that 95% of filters or more had material in the filter. So there was this
Makes sense. Yeah.
emotional thing. Oh my goodness, I don't want that in my brain or in my patient's brain or my family member's brain. So they approved it even though the study is negative. And so I think now if you take this data, right, overall it's negative. So I think most centers who were not using this filter will continue to say, well, I now have proof why I don't need it. And look, the stroke rate was overall was only about 2.2%, so the stroke rate is pretty low. Okay. In real life, though, both you and me know we treat patients sometimes who are very complex, right?
Mhm.
And we're doing procedures where we're modifying leaflets, there's lots of calcium. So in those patients, we may want to use a device because their risk of having a stroke is higher. So I think the study says maybe routine usage every day doesn't make an impact. We don't know if selective usage, if we can choose patients who are at higher risk, if those will benefit, because a little bit, I'm struck by the fact how disabling stroke was reduced. Okay, and those are the bad strokes. I'm also struck by the fact, in my center, we use a lot of we've used a lot of embolic protections, and when I look at the stroke rate over the last 4 years, um, all our all our disabling strokes were in patients who were not protected, who had no embolic protection. We never had a disabling stroke in a patient with embolic protection. So I'm a little bit
That's an
clouded by my
important.
own personal data. So I would say overall, there's still a role for it selectively. But I think what the study says to me is that maybe we need better devices, right? The Sentinel was a good device to start with. It's very safe. There's no evidence of harm, but maybe we need better devices that will give us better protection. And so I think we should continue to study this field and to study new devices.
Thank you for that. So, last but not least, PCR is about education. So, how do innovation, clinical trials, and education all come together? In my humble opinion, there are many instances of high quality data which are not really translated into practice. So, it's sort of a evidence practice mismatch, but in a way that you have evidence, but the device is either not used or the technique is not applied, or technology or technique are not applied in a sense that it should be, or to the point that they should be. And I think there are several examples which the two of us can mention, and I'll start maybe with the intracoronary space. So intracoronary imaging, for example, there seems to be ample evidence, at least with regards to complex PCI, that it helps. And maybe education is the right tool to improve the adoption and to try to maximize the benefits that have been seen in the trials, now translating them into everyday practice. So intracoronary imaging is, I think, a good example where education, so when you ask what's new in education, education is great for, let's say, younger physicians, and it's unanimously accepted that you need to have a fellows course, that you need to provide education for new generations. However, it is often not recognized that we all need it, that even senior physicians need it. And I think intracoronary imaging is a nice example. So in order for intracoronary imaging to be efficient, we need to pin down the educational elements that are needed and that need to be taught, how to use it, in which lesion subset, and to which end. And I think that's an example for that. But would you have any examples which are similar in the structural space?
Yeah, absolutely. I think again, it rounds off everything we're talking about, right? So you innovate, you develop a new device, you then study it and do the randomized trials, and then nobody uses it, right? And electrocoronary imaging is a perfect example. I mean, we've done all the studies for years and no one's using it. But hopefully now that it's a class one indication, more and more people will use it. I think in the structural space, I'm seeing something very similar for mitral tear in functional MR, in secondary MR. For a long time, people were doing it. There was really no data. Then now we have two very positive studies, right? We have COAPT from the US and we have the Reshape study from Europe, both showing, that you improve quality of life, you decrease heart failure hospitalization, and in COAPT patients, you decrease mortality, right? Yet, when you look at the numbers of patients who are undergoing mitral tear for functional MR, it's not increasing, it's flat, right? Yet we have a life-saving therapy that has, for the first time, a stronger indication than surgery. It has a class 2A indication, where surgery has a class 2B indication. So again, a perfect example of how do we change practice? And I think education is a really important part. It's educating our colleagues, starting how to start up, a proper mitral program. How do you educate people in your own institutions, whether that's the heart failure colleagues, the non-invasive colleagues, on the data and how this therapy doesn't take patients away from GDMT. This is a therapy that you add to guideline-directed medical therapy and can help save lives. So I think that's another great example.
Thank you very much, Azeem. Thank you very much for your time. It's been excellent. Thank you for your insights. And I think you wrapped it up actually nicely just a minute ago that we closed the circle. So EuroPCR is a nice platform for showing how the life cycle of medical therapies work, from innovation over clinical trials and then educating physicians on how to use these techniques and technologies for the best, for the benefits of our patients. Thank you very much once again, and I wish you all a nice summer. Hope to see you all soon.
Thank you. Bye, everyone.